Next is Tim Swan. He's going to be talking to us about coding and reimbursement update. Tim's at Marshfield Clinic and is our advisor for CPT. Wealth of knowledge for us.
Thanks, Jerry. Two things before I start. One, I apologize if I got a cold, largely from grandchildren vectors, this past weekend, but if I sneeze or cough or something during the presentation, I apologize up front. Number two, shifting focus now from future, not taking our eyes off the future, quality outcomes, quality measures, et cetera, to current state of affairs, coding and reimbursement. We still got to keep our eye on the current game. So in 2015, several new codes were created. There is an unshakable belief that cost savings cannot be found in the old component coding system. In fact, there have been several attempts to eliminate some of that duplication of effort that probably wasn't accounted for when the system, component coding system, was originally created 20 years ago. There is still some concrete belief at the CPT and RUC level that there is duplication of effort, and it exists particularly within diagnostic imaging, imaging guidance, and therapeutic procedures. So for 2015, the saga of code bundling continues. This year, all service lines have been impacted in some fashion. So let's get started. We'll take a look at some of the codes. We'll start with non-vascular interventions and talk about joint injection and aspirations, myelography, vertebroplasty and kyphoplasty, and some Category 3 code revisions. With regard to joint injections, we now have some updates to those codes that specify without imaging guidance to differentiate them from new codes that have been created. The new codes are complementary to these modified injection codes, but they do specify with imaging guidance. This bundles the imaging, supervision, and interpretation into the injection procedures. A reminder, don't report an additional S&I an S&I code with these procedure codes. Next, we'll review myelography codes that also bundle radiologic supervision and interpretation. These are all lumbar injection procedures with individual codes based on the region of imaging, the cervical spine, the thoracic, or lumbosacral regions. When two or more regions are imaged together in a single procedure, 62305 is the code to report. Note that 62305 includes imaging of the entire spine when performed from a lumbar injection. There have been extensive revisions to existing myelography supervision and interpretation codes by use of exclusionary parentheticals, effectively limiting these codes to use with cervical injections. Codes frequently reported together screens in the CPT RUC process have not yet mandated that these codes be bundled with their cervical injection counterparts, likely due to the relative infrequency of use compared to the lumbar injection codes, but I expect to see these codes bundled in the future, so stay tuned. Vertebroplasty and kyphoplasty have 6 new codes. The procedure codes are inclusive of moderate sedation, bone biopsy when performed, and imaging guidance necessary to perform the procedure. 3 of the new codes pertain to vertebroplasty in 2 anatomic regions, cervical thoracic and lumbosacral. Only one of these codes is reported for the vertebral body in the first anatomic region where intervention occurs. Any additional vertebral bodies requiring vertebroplasty in the same session are reported with an add-on code 22512. When treating the sacrum, sacral procedures are reported only once per encounter. Fundamental to the proper use of these codes is the ability to differentiate vertebroplasty from kyphoplasty. Go back here. Vertebroplasty stabilizes, vertebroplasty stabilizes a compression fracture, while kyphoplasty remodels the bone and by usually use of a balloon and injection of cement subsequently. That essentially is an augmentation of the vertebral body to restore the height. We have artfully used the term vertebral augmentation to differentiate kyphoplasty from vertebroplasty. You'll note the RVUs that have been assigned to these. There's been some loss of RVUs compared to the component codes previously. Category 3 codes, 200T and 201T, for percutaneous sacral augmentation have been revised to align with the services described in the last slide. The original sacral kyphoplasty procedure codes have been bundled to include imaging guidance and bone biopsy. Next, we'll move on to vascular interventions, where we'll look at the new codes for fenestrated endograft planning, great vessel stenting from an antegrade approach, and some editorial changes relative to arterial stenting in general. The Fenestrated Endograft Planning Code 34839 is a new planning code describing a minimum of 90 minutes physician time planning for fenestrated visceral aortic stent graft placement. This code cannot be reported when performed the day before or the day of the endovascular procedure. The code is intended to report the significant amount of work required to plan for, order, and order a custom-made endoprosthesis. Please refer to the 2015 CPT manual for complete instructions on the use of these and other fenestrated graft codes. Stenting of the left common carotid artery or the innominate artery via an antegrade approach, most often from the groin, became an orphan procedure when new stenting codes were recently created. 37218 addresses this deficiency and describes the work of antegrade stenting of these vessels, including all selective catheterization, diagnostic imaging of the ipsilateral cervical carotid or innominate artery, balloon angioplasty if performed, and radiologic supervision and interpretation. If diagnostic arteriography does not confirm the need for a stent procedure, you're instructed to use the appropriate diagnostic arteriography codes from the 36200 series to report the diagnostic study. This new code fared relatively well in valuation relative to its cervical carotid counterpart. Several editorial revisions have been made to the stenting and embolization codes. The phrase "other than for lower extremity arteries for occlusive disease" was added to codes 37236 and 37237 to prohibit the use of these codes when more specific lower extremity codes apply in the 21 to 27 series. Embolization introductory language was also modified to make 3 points clear. Embolization does not include diagnostic angiography. Catheter placement may be separately reported, and diagnostic angiography may be separately reported. In the realm of interventional oncology, there were several changes to ablation codes in the lung, liver, and bone. Two new CPT codes have been created or established specifically for reporting percutaneous cryoablation procedures of bone and liver tumors. 20938 reports cryoablation of one or more bone tumors, including adjacent soft tissue when involved by tumor. This code includes any modality imaging guidance when performed. 47383 reports cryoablation of one or more liver tumors, but excludes imaging guidance. Imaging guidance or vascular catheterization for angiographic guidance are separately reportable with this code. I should also note that the RF ablation code 20982 has been revised to include ablation of adjacent soft tissues if involved by tumor. This procedure is also inclusive of imaging guidance. As you can see, the RVU values of those codes fared relatively well. Sorry, the slide jumped ahead. There are multiple extensive miscellaneous editorial revisions to exclusionary and instructive parentheticals. Among these are changes to fluoroscopic, ultrasound, and MRI guidance codes. Again, please see the 2015 book for specific information about the use of these codes. Category 3 code 340T was made available for use beginning in mid-year 2014, and it is now published in the 2015 manual as a Category 3 code for use for pulmonary ablation of tumor. There are, from our perspective, unintended consequences to the flurry of code bundling that has been occurring. Some would argue that these consequences are intended since the pool of money available for physician services is relatively a zero-sum game. The new bundled vertebroplasty codes were hardest hit this year, losing a significant amount of their component coded value. The value loss was not as much as IVC placement hit that we took a few years ago, but it was a hit nevertheless. Be aware that there will be local coverage determination issues with regard to sacral vertebroplasty, as these will have to be fought on an individual carrier level basis. Early indications are that most of these issues will be resolved by educating the carrier medical directors on the existence of a Category 1 code and differentiation between vertebroplasty and sacral augmentation. On the other hand, most of the other codes that went through the process this year changed relatively little. RF ablation and laser vein ablation codes were revalued this year and did take a 22% hit, but overall there were a couple of wins with new codes for carotid and innominate artery stenting and the addition of cryoablation codes. In total, I think we'll come out relatively even overall, or maybe just a slight decrease. So that's a whirlwind tour of the bundling of codes for 2015. In aggregate, there will be a minor reduction, as I said, but we've done relatively well in preserving value. So what's ahead? There'll be more bundling in 2016. I anticipate changes on the horizon will include biliary and GU procedures, sclerotherapy, intracranial thrombectomy, intravascular ultrasound will also be looked at. So stay tuned and keep you apprised of those changes as they come through. In summary, the 2015 changes we've covered this afternoon include cryoablation procedures, spinal diagnostic and treatment procedures, peripheral vascular stenting and embolization procedures, joint injections and aspirations, and reimbursement issues. And again, if you have any questions, please feel free to email me. My email address is up here. I'd be happy to talk to you after the session's over, too. Or you can contact SIR through the SIR webpage. There's a specific form on the webpage. It's also this address that you can fill out, and SIR staff will get it through to whoever is the best one to answer the question. So thanks for your attention.